Hi friends, we are talking about imaging instruments. This lecture is to keep you updated with the latest trends in entrance exams. We have been noticing in NEET, AIMS, a little glimpse in PGI, JIPMER, and a major glimpse in FMG August 2020. More and more of images are being asked. I have tried to compile all the images at one place, instruments at one place. So this lecture will take you through all the exams, all the images required in orthopedics. The first image, the bread and butter, the basics of orthopedics, basic X-ray. An X-ray can show you the bone. It can show you the marrow in the center, the cortex. But more importantly, the soft tissue plane, the muscle and the fat, and in between the fascia. What it does not show you is the cartilage, which is called as the joint space. An X-ray can show you the joint space, which is normal. In an X-ray, if the joint space is reduced, it means the cartilage is getting destroyed. It means there is arthritis, which means destruction of the cartilage. Normal joint space, destroyed. X-rays of different body parts. Shoulder, they just love two things, the coracoid, subscapularis. This is the coracoid, the bone palpable just beneath the clavicle on the lateral side is coracoid. This happens to be the start of a lots of incisions around the shoulder. The highest bony landmark, the clavicle. The next to it, acromion. The head, 4 times the glenoid. Ratio, 4:1. Shoulder. Elbow. They love to ask the capitulum. They will point an arrow here and ask you which bone is this. The second is radial head. And why the significance? Because this is the order of ossification. Capitulum, 2 years. Radial head, 4 years. Medial epicondyle or internal epicondyle, 6 years. Trochlea, 8 years. Olecranon, 10 years. Lateral epicondyle, the last one, 12 years. So this is table of 2. Then we come to wrist. Radiocarpal joint, radius, over which the scaphoid sleeps. And then comes the lunate. Scaphoid ossifies at 5 years of age. When we look at the lateral view, it looks like the moon, the lunate, the moon. And in the same axis, you have the largest carpal bone, the capitate. The largest carpal bone, the capitate. Remember one thing, friends, the first metacarpal is anterior. The thumb is anterior. Remember this. So the displacement of all the bones, if you go with reference to thumb, you can make out they are going anterior or posterior. Coming to the next, when I look at the pelvis, they love this area. SI joints, the sacroiliac area. And the second thing they love is the Shenton's arch, made by upper end of femur, the pubic rami. And whenever there is a fracture of pubic rami, upper end of femur, or a joint dislocation, this Shenton's arch is broken. The inflamed SI joints, called as sacroiliitis, is seen in ankylosing spondylitis, which is a spondyloarthropathy. Going to advanced investigation, if you want to look at the calcified tissue or the cortex, CT scan. C for CT, C for cortex, C for calcification. C. Similarly, M for MRI, M for marrow. Most of the diseases in orthopedics, they have a base from the marrow. That's why in my subject, MRI is #1 specialized investigation. X-ray is usually the first one, followed by MRI. MRI can also show you the cartilage and then the soft tissues at the back. So just apart from the calcified tissue, MRI is good for everything. If you look at the different cuts, you have the sagittal cut, the coronal cut, or the transverse cut. They will show you the sagittal cuts of the knee, and they can ask you what structure can you see. So if I look here, the structure which goes towards the anterior part of the tibia is ACL, anterior cruciate ligament. These are the sagittal cuts of the knee. And the one that goes most posterior is the posterior cruciate ligament. PCL restricts external rotation of the knee. ACL restricts internal rotation and hyperextension of the knee joint. CT will look more white, calcified. MRI suppressed. When we look at the reaction of a bone to the damage, that's called as periosteal reaction. Periosteal reaction means the bone is getting destroyed. If the disease is benign or slow grumbling, you will have single layer or narrow zone of periosteal reaction. But if the disease is aggressive, then it will have widespread damage. You can have multiple rays coming out. You can have multiple layers over the bone called as onion peel, multiple rays sun ray, or a triangular piece of bone underneath the periosteum called as Codman's triangle. All three, they mean chronic or malignant process. So, single layer solid reaction, benign tumors or osteomyelitis. Day 7 to day 10. White zone, onion peel, sun ray, Codman's triangle, malignant or chronic process. You can have sun ray appearance, any malignant bone tumor, but usually osteosarcoma. Triangular piece of bone underneath the bone, any malignant bone tumor, usually osteosarcoma. Multiple layers over the cortex, called as onion peel reaction, usually Ewing sarcoma. Remember, all these periosteal reactions, they are radiological appearances. And these radiological appearances can never be diagnostic. Diagnostic is tissue, biopsy. If it's infection, grow the organism on culture media. If it's a tumor, diagnose on histopath. So, the radiological appearances. Sun ray appearance or Codman's triangle, osteosarcoma, but can be seen in any malignant lesion. Onion peel appearance, again chronic process or malignant lesion, but if you have to pick one, Ewing's. Soap bubble appearance, giant cell tumor followed by adamantinoma. Patchy calcification, patches. Cartilaginous tumors, chondrosarcoma more than chondroblastoma. Uniform calcification, osteogenic tumors like osteosarcoma. This is patchy. This is homogeneous. This is soap bubble appearance. If you see soap bubble appearance involving the lower end of radius going till the joint, what should come to your mind? Giant cell tumor. This is extremely, extremely important. The bone infections. Staph aureus is the organism that we must remember. Acute osteomyelitis. The image can be inflamed skin, a solid periosteal reaction. But if you have to take up one image that has been thoroughly coming, it's chronic osteomyelitis. A cavity filled up with fluid with a dead bone. The dead bone is called as a sequestrum. Sequestrum means isolated in a cavity, surrounded by a live bone called as involucrum, and then the draining sinuses called as cloacae. In fact, they give you a history, an image, or label a sequestrum or an involucrum and ask you the same. They can give you a deformed sclerosed bone. They can talk to you either in the femur or once they had asked at the upper end of humerus. This was the image that came. This is sequestrum, surrounding it is involucrum. This gives you an image of a rim on an MRI called as rim sign, a feature of chronic osteomyelitis. Coverage of the skin, they can do a vacuum closure called as negative pressure wound therapy, an image that featured in AIMS November 2019 exam. They can ask you infections of hand, the most common being the infection of the nail bed called as the paronychia. The most commonly asked, the infection of the pulp space called as Fallon or Whitlow. Coming to the chronic granulomatous infections in India, tuberculosis tops the charts. TB will never involve a single vertebra. It is a two vertebral disease called as paradiscal involvement. Rarest in TB is facet joints or the posterior structures like spinous process. If you look at the hip joint, the number one affected area in TB is acetabulum. And then you have an area over the upper end of femur called as Babcock's triangle, which is number 2. So on femur, Babcock's triangle. In the hip, acetabulum. This came in FMG August 2020 exam. Replacements. They can just show you an image. If you see a whitish area in the femoral canal and the acetabulum, this is a cemented hip replacement. And if you don't, it's an uncemented hip replacement. When you look at a bone, you know, the ends of a bone, the epiphysis, the metaphysis, they are the upper or the lower ends. The metaphysis is the most common area where infections and tumors occur, except for one tumor which occurs in the diaphysis. Very commonly, you should remember, Ewing's sarcoma. Ewing's is diaphyseal. Metaphysis is the most common location for infections and tumors. Let's look at the common images for bone tumors. Single cyst, upper end of humerus, unicameral bone cyst. U, B, C. Uni means single, cameral means camera. Single cameral bone cyst, unicameral bone cyst, also called as simple bone cyst, can have a broken fragment at the base, called as fallen leaf or fallen fragment sign. Multiloculated towards a corner, but still before the fusion of epiphysis to metaphysis. This fusion of epiphysis to metaphysis is called as skeletal maturity. So this is before skeletal maturity. In the metaphysis, multiple septae, multiloculated, usually seen in tibia, towards one side, aneurysmal bone cyst. Upper end humerus, involving the epiphyseal area with calcification. Codman's tumor, also called as chondroblastoma. Codman's triangle was a periosteal reaction. Codman's tumor is epiphyseal tumor with calcification, upper end humerus. Bony growth away from the joint. Growing as the child grows, the growth stops. The growth stops with skeletal maturity. Osteo, bone. Chondroma, cartilage. Bony growth with a cartilage cover. When you will touch it, you will feel the bone and the cartilage both. When you click an X-ray, cartilage is not seen on X-ray. So larger to feel, smaller on X-ray. It is not a malignancy. It is a growth abnormality, developmental malformation. Night pain, relieved on taking salicylates. A tumor right in the cortex, osteoid, osteoma. They have a growing center called as a nidus. Nidus has a lysis in the center surrounded by sclerosis. Osteoid, osteoma. And then N chondroma. In the medullary cavity, cartilaginous tumor. Most common tumor of bones of hand and feet, N chondroma. On biopsy, you see hyaline cartilage. Multiple N chondromas, Ollier's disease. O for Ollier's, O for only N chondromas. Multiple N chondromas along with hemangiomas, along with calcified superficial veins called as phleboliths. Maffucci syndrome. M, Maffucci. M, many things. This image can come in the exams. And then the tumor which the examiners love. Giant goes till the joint. Giant cell tumor going till the joint. The only tumor which can go till the joint, in fact, according to Robbins, in all the joint. Classical area, lower end femur. It can go right till the upper end tibia. It can go right till the hip. Commonest location for GCT is lower end femur. Remember that. Lower end femur is also the commonest location for osteomyelitis. Lower end femur is also the commonest location for osteosarcoma. But they usually show you lower end radius going till the joint. If you remember, the shepherd will hold a stick, a crooked stick. If the upper end femur looks like the same, called as shepherd crook deformity, it is a bony replacement by a fibrous tissue called as fibrous dysplasia. Fibrous dysplasia, again, like osteochondroma, is a developmental abnormality. If you see vertical striations on a vertebra, it's called as jail bar appearance, corduroy appearance. This is seen in hemangiomas. Osteosarcoma, homogeneous calcification, lower end femur. Skulls, multiple lytic lesions, punched out lytic lesion, as if punches have been taken out. Multiple myeloma, tumor of plasma cells. You know, examiners nowadays they love skulls. So punched out lighting lesion, multiple myeloma. Beveled or sloping lytic lesions, eosinophilic granuloma. Large lytic lesions, permeative lesions. Langerhans cell histiocytosis. Dot 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 dot. As if salt and pepper have been sprinkled. Hyperparathyroidism, because it's a bone resorption disorder. Opposite of it, bone formation on the skull, cotton wool skull, a feature seen on Paget's, which is also called as osteitis deformans. Examiner loves it. You know, this image can come to you with distribution of different nerves. For a person of my brain level, I can't register this. So I devised a method. Do this. It's like a horn on the head. The tip of index finger supplied by the median nerve, little finger ulnar nerve, dorsum of first web space, radial nerve, median, ulnar, radial. Done. Don't need to remember the whole thing. This will answer everything. When I look at lumbricals, lumbricals is something that examiners love. We have 4 lumbricals. The lateral 2 supplied by the median nerve. The medial 2 supplied by the ulnar nerve. Lumbricals, they help you make a L in your hand. L. L for lumbricals. When they are paralyzed, you have a claw hand. So, when we talk about ulnar nerve supplies the palmar interossea, which adduct. If you give a card to a patient and ask him to hold it between the fingers, it's called as the card test. Palmar interossea adduct. Ulnar nerve. Card test. Similarly, you have a muscle called as adductor pollicis, a muscle of thinner eminence, but supplied by ulnar nerve. If you give book to a patient, he can hold the book between the thumb and palm. This is adductor pollicis, the book test. But if my ulnar nerve is paralyzed, I will flex my thumb and hold the book, called as Froment sign. How am I flexing it? By the function of my muscle flexor pollicis longus, which is supplied by anterior interosseous nerve, median nerve. Helps you make a fist. Paralyzed, these 2 fingers stand out, called as pointing index. The ulnar 2 fingers will flex because FDP, flexor digitorum profundus, medial half is supplied by ulnar nerve, pointing index. When a pope speaks to a community, that's how he does. Same, it's called as benediction attitude. When you clasp your hands, if these 2 fingers stand out, same, Ochsner clasp test. Similarly, the supply of a median nerve, anterior interosseous nerve, supplies the flexor pollicis longus, FDP lateral half. It helps you make OK in your hand, called as OK sign or Kilo Nevin sign. OK sign or Kilo Nevin sign talks about anterior interosseous nerve, a branch of median nerve. When we talk about lumbricals, they paralyze claw hand, and opposite of it, this is called as knuckle. The MCP area, knuckle bender splint. Used for both ulnar and median nerve, but ulnar more than median because that's how it is, more common. The brachial plexus palsies, they become a trend nowadays in the exams. If you have involvement of C5 and C6 nerve root, it will lead to something called as a waiter tip deformity or a policeman tip deformity. And if you have the involvement of the median nerve in a carpal tunnel. So when you do the Ulta Namaste, this is phalanx test. Seedha Namaste is a reverse phalanx test. This tells about if in this position a patient has tingling in the distribution of the median nerve. It's carpal tunnel syndrome. Similarly, when we talk about the radial nerve, the commonest nerve damage with the best prognosis, it will present with a wrist drop because it supplies the wrist extensors and its supply, the posterior interosseous nerve, does the extension of metacarpophalangeal joint. So if posterior interosseous nerve is paralyzed, finger drop, radial nerve, wrist drop. This is a splint for it, cock-up splint, opposite of it. C8 and T1 nerve roots, they are involved in thoracic outlet syndrome. So if you ask a patient to do this for 3 minutes and he has numbness and tingling in the distribution of C8 and T1 nerve roots, which is the ulnar distribution of hand and forearm, it means a patient has thoracic outlet syndrome. He also will have decrease or absent radial pulse in doing this. Very common. Allen's test tells about the patency of the radial artery and the ulnar artery. You will ask a patient to pump the hand multiple times, squeeze it, compress both the radial and the ulnar arteries. Ask him to open the hand. It will look pale to you. Release the pressure on the radial artery. If the radial artery is patent, the hand will become pink or red. If not, it will stay pale. Repeat the test by removing the pressure on the ulnar artery. If it becomes red, it means it's patent. This test is done to see if you are cannulating the radial artery, whether the ulnar circulation is sufficient to maintain the hand or not. Allen's test video came in the exams. Roos test video came in the exams. Trauma. If I have to pick one area, one chapter, upper limb trauma, that too shoulder dislocation tops the chart. Remember one basic rule. Whether it's hip or it's shoulder, if the head is below the joint, it's anterior. Second point, the arm or the thigh will be abducted. So it will be down and it will be out. Out because the arm or the thigh is out. Down because it's below the joint. When I look at posterior, the head will be just at the level of joint and the arm or the thigh will be adducted. The second image that can come from upper limb, Cubitus, varus. Varus means towards the midline. This is varus. The angle between the arm and the forearm is the carrying angle. If the forearm goes towards the midline, it's varus. If it goes away, valgus. Valgus is a L. L means lateral. Cubitus varus is seen in malunion of supracondylar humerus fracture. Cubitus valgus in non-union of lateral condyle humerus fracture. When we look at the third important image, it's around the fractures of forearm. You can have the Monteggia fracture, where the medial bone or the ulnar fractures with a dislocation of the radial head. Or you can have the Galeazzi fracture, fracture of radius in the lower part towards the ground with dislocation of distal radio-ulnar joint. You can have fractures around the wrist. You can have a fracture of the lower end of radius. The distal fragment goes posterior. Why posterior? Because thumb is anterior. Or this is called as Kohli's. So Kohli's goes posterior. Priyanka Chopra, PC. Whereas if the fracture occurs, it goes anterior towards the first metacarpal. Anterior is Smith. Kohli's will produce a dinner fork deformity. Smith, opposite of it, garden spade deformity. Examiner loves Kohli's. The scaphoid blood supply, it comes from the distal to proximal. If it breaks in the middle, called as the waist, that's how the proximal pole becomes white. White means dead, called as avascular necrosis. This area is loved by the examiner. Fracture of base of first metacarpal along with a pull of a muscle is called as first carpometacarpal dislocation or Bennett's fracture dislocation. Whereas only fracture of base of first metacarpal is called as Rolando. Remember, both Bennett's and Rolando are intraarticular. Bennett's is a fracture of base of first metacarpal with dislocation. Rolando, only a fracture. Both are intraarticular. When you look at the wrist, right in the center is radius, followed by the lunate, then capitate. They are in one line. If only the lunate comes out, it's a lunate dislocation. When the lunate stays in, everything else comes out. Perilunate dislocation. Perilunate is more common. But if the lunate comes out, it looks like as if it's a spilled teacup sign or a pie sign, pie-shaped sign. Very commonly asked in the exams. Nowadays, they are showing you the spine a lot. They can ask you the curvature of the spine. Remember, the curvature of the spine, they go like this. So, the cervical spine goes in. Cervical lordosis. Thoracic comes out. Thoracic kyphosis. Lumbar lordosis. This lumbar lordosis was asked in the exams, which is the normal curvature of spine. Lumbar lordosis. Similarly, if there is a lateral curvature of spine, it's called as scoliosis, and for that, Cobb's angle is done. Scoliosis, if there is no structural abnormality in the vertebra, it's idiopathic, commonest variety. If there is a defect in the development of vertebra, congenital scoliosis. In congenital scoliosis, you have to sometimes see what angles are we having. If the Cobb's angle is less than 30, observe. 30 to 45, apply a brace. More than that, operate. If you have to look for the stability of the hip joint, you have to look at the normal acetabulum, normal head and neck, the superior gluteal nerve which supplies the gluteus medius and minimus, the abductors of the hip. If all of them are normal, you can stand on one limb and the opposite side, the unsupported side, stays straight. But if there is an instability, then it can't lift the pelvis up. The opposite side drops. So drop of the opposite side is positive, is the mnemonic. The second test after Trendelenburg test, which tells about the stability, is a Thomas test. Hugh Owen Thomas, famous scientist, gave this test which talks about hip flexion deformity. H.O. Thomas test. Now coming to some fractures of the spine. If there is a vertical injury, this is called as burst fracture. The C1 vertebra will burst open, called as Jefferson fracture. Mnemonic is JART. Jefferson's is a fracture of atlas, whereas Hangman's is a fracture of second cervical vertebra or axis. C2 vertebra over C3 slips, called as spondylo, means vertebra. Listhesis means slip. So C1 and C2 are important area. Remember, atlanto-occipital, between the atlas and the occiput. The first movement of the body is a yes, flexion extension. Atlanto-axial, C1 and C2. The second movement of the body is a no, rotation. Remember. And then if there is injury of the spinous process of lower cervical or upper thoracic process, Clay-Shawler's fracture, because the Clay-Shawlers, they keep heavy weight here and throw it. This throwing action avulses their spinous processes. When we look at the upper end of femur, it has a trabeculae. These trabecular pattern, along with the acetabular patterns in the head or the neck, they form a linear axis. When there is a fracture of the neck, these axes are broken, which is used in Gardner's classification. This is what is fracture neck femur. And if there is a fracture from the intertrochanteric area, it's fracture intertrochanteric area, also called as extracapsular injury, for which nowadays this implant is very commonly used. Cephalomedullary implant means an implant going in the medulla, the nail, and with a screw you're holding on to the head of femur, called as cephalomedullary implant, also called as the proximal femoral nail. What are these fractures? There's a fracture of upper end humerus. How is it classified? Nears. Into how many types? 4 types. What is this fracture? Supracondylar fracture humerus. How do you classify it? Gartland's classification. Most common is posterior type, and posterior also posteromedial because of the pull of the triceps. What is this fracture? Montagia. How do you classify? Bedo. Which is the commonest type? The radial head going anterior. So it's a fracture of ulna, but the dislocation of radial head decides the name, anterior posterior. So type 1 anterior is the commonest. That's what is asked. Galeazzi. This is nightstick. Isolated fracture of the ulna as if there's a blow on the ulna by a watchman to the thief, called as nightstick fracture. Or a fracture of lower end radius with posterior displacement, called as Colles, PC. And when it goes anterior, Smith. Or there's a fracture involving the radial styloid going to the joint, Schoffer's fracture, very commonly asked. Or fracture of neck of fifth metacarpal, Boxer's fracture. Or there can be a fracture involving one side of the posterior part of the pelvis, the other side of the anterior part of the pelvis. And it's as if the handle of a bucket becomes unstable. Or you can have an injury hinging on the posterior elements, the anterior part of the pelvis opens, called as open book. So bucket handle is a B, open book has a B. Both are B type injuries of the pelvis. Or you can have an injury ipsilateral, bucket handle, anterior posterior, contralateral. But if there's an ipsilateral injury of anterior posterior element called as Melgagne injury, which came in 2018 as an image in JIPMER. Or fractures of anterior but both sides, straddle fracture, superior inferior pubic rami, bilateral. So 4 type of pelvic images should be remembered: straddle, open book, bucket handle, Melgagne. And then fracture involving the upper end of tibia, lateral tibial plateau, bumper fracture, occurs because of a bump on the lateral side of the tibia, because of the bumper of the car. Or comminuted fracture of the lower end tibia, called as intra-articular fracture, lower end tibia, pylon fracture. Or there can be a fracture involving the malleoli, the lateral malleus, lower end fibula, the medial malleus, the medial part of lower end of tibia, posterior malleus, the posterior part of the lower end tibia. When all 3 malleus break, Cotton's fracture, mnemonic CT. or they can be fracture of only the medial and the lateral malleus, called as a Pott's fracture. Or when the vertical height occurs, trauma occurs, aviator fracture occurs to the neck of talus. And then the Chopard's. Chopard's is an intertarsal fracture. It's an anatomical area. Chopard's amputation, intertarsal amputation. Chopard dislocation of fracture to the intertarsal area. And when it occurs to the tarsometatarsal area, Liszt Franks. So it's a tarsometatarsal area, common injury. When there is a fracture involving the base of the fifth metatarsal, remember 2. If it's involving more proximal, pseudo-Jones. When it is a little distal, Jones. Jones is also called as a dancer's fracture. And when there is a fracture involving the neck of second or third metatarsal in repeated stress, called as a March fracture. When you apply a splint or traction, simple figure of 8 bandage for one of the commonest fractured bone in the body, clavicle. Or you can give a U slab for fractures of humerus. Or you can give a hanging cast for again the fractures of humerus. Or you can apply a Dunlop traction for supracondylar humerus. So Dunlop or Smith traction is for supracondylar humerus. Smith is not for Smith fracture. Although the treatment of supracondylar humerus is reduction and fixation or cast, but this was in older times. Or you can have a hand shaking cast for Colles fracture, or a glass holding cast for the scaphoid fracture. Remember, the examiners love these 2 fractures. Or you can have a mallet finger splint. What is a mallet finger? It is an avulsion of extensor tendon from the distal phalanx, treated conservatively with a splint for 6 to 8 weeks. Mallet finger splint, or Milwaukee brace or Boston brace for the lateral curvature of spine, called as scoliosis. Fractures involving the knee joint or the patella, cylinder cast, also called as a tube cast. But when there is a fracture involving the tibia, you can give a patellar tendon bearing cast and allow the patient to bear the weight. This is functional cast, and you can have some splints or traction, Bohler, bronze splint for fracture of the femur, the knee or the leg. 3 different pulleys are there. Coming to the fixation when you're operating, you can do a tension band wiring for fractures of patella, olecranon or medial malleus, where the convex surface, also called as a tension surface, you will put a wire or a plate so that the distraction forces, because of the pull of a muscle, the distraction forces because of the pull of a muscle cannot take the fracture fragments away. In fact, when there is a pull, the wire or the plate which is there on the tension surface will provide the compression. So it's conversion of distraction forces into compressile forces by application of wire or a plate on the tension surface, called as tension band wiring, also called as tension बंद वायरिंग, दूरियों को नजदीकियों में convert करना, conversion of distraction into approximation. You can have tractions for which you can apply a Steinman pin or a K-wire along with a Bowler stirrup. This Bowler stirrup allows a good space between the limb and the traction weight to be applied. So the traction can be skin traction, where you can give up to 3 to 4 kgs, or skeletal traction, where you can give 10% of the body weight, but some literature says up to 20 kg. You know what is a skeletal traction? The pin will go through the bone and then apply a traction. When you fix it, you can use a wire, K-wire, called as Kirshner wires, or a plate. The initial plates were simple. They were put on the surface. They were called as dynamic compression plate because when you were tightening the screw, they were applying compression at the fracture site. Disadvantage: these plates were denuding the bone of the blood supply. So they came with new plates, where they had undercut surface called as limited contact dynamic compression plate, LCDCP. All these plates were fixed up with screws: cortical bone, cortical screws; cancellous bone, the threads were a little away, cancellous screws; or the third type of screws, we'll talk about them, the locking screws. So when you were fixing the dynamic compression plate or limited contact dynamic compression plate, the screws were in the holes of the plate, and they could come out if the bone was not uniting in a proper time. To circumvent this problem, they came with threads on the screw head, threads on the hole, and then this will lock, the head will lock with the whole threads on the plate. Now, if there's a failure, the whole plate has to come out, which is practically not possible. This is called as locking compression plate. They had two types of holes called as combi holes. One was with the threads, one without the threads. Simple screw or a locking screw can be placed in it. If you were dealing with lower limbs or long bones like the femur or the tibia, you had to put nails, intramedullary rods, and you were locking them with screws so that the rotational malalignment does not occur. These are external fixators which were used for open injuries. Open injuries which are classified by Gusklo-Anderson classification, and these are the external fixators which were used for them. When you have to lengthen the limb, a variety of external fixator called as rail fixator can be used. But the classical one, which is allowed to increase the length of a limb at a rate of 1 millimeter per day, which works on the principle of distraction histiogenesis, called as Elizarov external fixator. Some instruments that you use along with the implants and prosthesis: osteotome for cutting the bone, bone cutter, help you to cut the bones like ribs or prepare your grafts. Nibbler, create a cavity or freshen the margins. Nibbler, very commonly asked, in fact has been asked 2 times in last 3 years. Or you can curate out from a cavity, curate, cleaning out, scooping out. Or you can hold a bone when you are applying the fixation technique. You can have a simple bone holding forceps will have tooth. Anything that holds a bone should have a tooth. So bone holding forceps, any type of tooth. Or one side will have teeth, the other side will be smooth, called as bone plate holding forceps. Plate side will be smooth, otherwise it will corrode the metals. These are the bone holding forceps. If I have to choose 3 chapters: upper limb trauma, nerve injuries, and arthritis. In arthritis, hand is something they love. Osteoarthritis involves the joints like this, OA. So DIP, PIP, spares the MCP and the wrist. RA, the joints which are towards you are involved in RA. So OA, DIP, PIP, RA, PIP, MCP. So at DIP, the swelling is called as Haberden nose. Mnemonic is DH. At PIP, Bouchard's nose, but the classical is for scarpometacarpal joint. OA knee involves the medial joint space reduced. You will see whitening just beneath the joint called as subchondral sclerosis. The tibial spine will spike out. Projections will appear in the center. And in the non-weight bearing area, you will have bone formation, osteophytes. In the bone, periosteal reaction. In the joint, osteophytes, telling you getting damaged. Knee replacement, one of the revolutionary surgeries of last 100 years. If you look at RA, it will have two deformities, swan neck and boutonniere. In swan neck deformity, there is flexion of DIP, hyperextension of PIP. Why hyperextension? Because there is flexor damage of PIP, whereas boutonniere has extensor damage of PIP. So there is flexion of PIP, hyperextension of DIP. Boutonniere or buttonhole deformity. Psoriasis can have pencil in cup deformity. So in psoriasis, we have the pencil in cup deformity. SI joint, sacroiliitis, ankylosing spondylitis. It's an HLA-B27 positive condition. The entire skeleton appears white, called as bamboo spine, fused. There is squaring of the vertebra. In the intervertebral, in the interspinous areas, you can have calcification, and it can look like as if there is an inverted knife called as a dagger, sign, or there can be calcification along the facet joints, 3 layers, called as a trolley track sign. It can also have sclerosis at the edges of the vertebra, called as a shiny corner Romanes sign, all seen in ankylosing spondylitis. Inflamed great toe in a middle-aged man with history of alcohol is the deposition of uric acid, gout. Totally destroyed joint, very common in diabetes, Charcot's. Neuropathic joints, painless, swollen, deformed joints. If I look at metabolic disorders, if your bone is soft and there is pressure over it, it will take the shape of a cup called as cupping. The bony ends will become wide, splaying, and the edges will flare out. Normally the metaphyses come towards inside, go out. So cup is a shape, splay is a width, flare is a direction. Cupping, splaying, flaring. Splaying indicates rickets, mineralization defect. Give calcium, vitamin D, splaying comes down, cupping comes down, flaring comes down. You see a white line called as white line of Frankel, seen in healing rickets. Whereas if you have vitamin C deficiency, called as scurvy, you will always have this white line of Frankel. But there is calcification around the epiphysis, called as Wimberger ring sign. Wimberger ring sign, scurvy. So scurvy, whitening, सफेद X-ray. Rickets, widening, bony ends become broader. Spine, different X-rays. When you have stripes in the spine, as the rugby players have, rugger jersey spine, classical in CRF, also seen in osteopetrosis. When the entire skeleton fuse, bamboo spine, ankylosing spondylitis. If your vertebrae become white at the border, called as picture frame, completely white, ivory vertebra. When the vertebra becomes like a bullet, achondroplasia. So bullet-shaped vertebrae, achondroplasia. Whitish vertebra, Paget's disease. We had done whitish skull, cotton wool skull, Paget's. Whitish vertebra, Paget's. And when the bones are weak and the intervertebral space looks like a fish, it's called as cod fish vertebra, osteoporosis. More than osteomalacia. Coming again, CRF, rugger jersey. Bamboo, ankylosing spondylitis. Picture frame or ivory, Paget's. Bullet nose, achondroplasia. Codfish osteoporosis. They can show you this prosthesis, Jaipur foot or Satch foot. Solid ankle cushion heel, Satch foot is for Western lifestyle. Does not have ankle movements or subtalar movement. It's after an amputation you give this foot. Indian population, natural looking foot, designed by the great scientist Dr. P.K. Sethi. Can walk barefoot, allows the ankle movements and the subtalar movements. You can sit on the ground, walk on irregular surface, is cost economic. They can show you a spine MRI. This is a vertebra, disc out, causing the compression. Remember, the most common disc prolapse causing the compression is L4, L5, and it compresses the L5 nerve root. The most common nerve root compressed in human body. If there's a break in pars interarticularis, you have a superior articular process in a vertebra, which is like, if you see an oblique or a lateral view of a vertebra, it looks like a dog. The ear of the dog is superior articular process. The front leg is the inferior articular process. And the neck of the dog is called as area of interarticularis. Whenever I jump, I take a turn. All my forces, they go to this area. And this is a weak link. When it breaks, it's called as lysis. Vertebra is called as spondylo. Combo is called as spondylolysis. Break in the vertebra occurs at pars interarticularis. So break in the neck of the dog. Most commonly involves the L5 vertebra. When the neck breaks, the head falls. This is called as spondylolisthesis. So slip of L5 over S1, called as beheaded dog or beheaded Scottish Terrier sign, where spondylolysis is called as dog with a collar in the neck. Avulsion of extensor tendon, mallet finger, treated by a splint. Avulsion of flexor digitorum profundus from distal phalanx, jersey finger, treated by surgery. If your acetabulum is not well developed, it's shallow, the head will go out, called as developmental dysplasia of hip. Pathology, shallow acetabulum, Shenton's arch is broken. You treat them by keeping it abducted, called as Pavlik harness. They asked in FMG exam this time, abducted thighs, this harness was shown. What is the disease? Developmental dysplasia of hip, also called as DDH, shallow acetabulum. If the blood supply of the head or the epiphysis goes in a child of 4 to 8 years, it's called as avascular necrosis of the femoral epiphysis, Perthes disease. Or if the epiphysis slips over the metaphysis, in fact the epiphysis stays there, the metaphysis moves, called as slipped capital femoral epiphysis, misnomer. The metaphysis moves. When you draw a line over the neck, normally a part of epiphysis is above it. When it's not, it means it's slipped out. This line is called as Klein's line. When there is nothing above it, it's called as Trithoven sign. Thickened calf, hypertrophied, seen in the mutation of a dystrophin gene, the largest gene in human body, called as Duchenne muscular dystrophy. There is pseudohypertrophy of calf and tongue. It's a proximal muscle weakness, and child takes the support of his body to climb up, called as Gowers sign. If the cervical spine does not fragment, they fuse together. It's called as Klippel-Feil syndrome. They have a short neck, low hairline, restricted neck movements. In Klippel-Feil syndrome, in 50% cases, you have short high scapula, called as Sprengel shoulder. Why is it short high? Because scapula comes from top to bottom during growth. Then the cervical spine does not develop properly, it gets stuck up. So short, high scapula. Congenital talipes equinovarus or CTEV. There are three important things which are lost. You have an equinus at ankle, you have varus at subtalar joint, and you have adduction at forefoot and midfoot. The most important joint which involves is stalo-calcaneonavicular complex. And in CTEV, the treatment is cast at birth. So they have cavus, that is increase plantar arch. They have adduction, forefoot and midfoot goes towards midline. We have varus, subtalar joint inversion, equinus, plantar flexion. So cave. When you correct, first correct the cavus, then adduction, then varus, then equinus. In pediatric population, because of trauma, only one cortex breaks. It's called as green stick fracture. When there is improper development of a tibia, because there develops a pseudoarthrosis. Arthrosis between two different bones, like knee is an arthrosis between femur and tibia. Pseudoarthrosis occurs in between the joint. Pseudo because it's not a joint. Arthrosis because there's a fluid which looks like a joint. Cartilage-like coverage. Intraoperative diagnosis. It is associated with neurofibromatosis. Congenital pseudoarthrosis of tibia has an anterolateral bowing of the tibia. And then when there is maldevelopment of the lower end radius, it leads to the prominence of the lower end of ulna called as maid lung deformity. Common in females, 50% cases are bilateral, associated with Turner syndrome, functions are good. And then if there is a congenital fusion between radius and ulna, the pronation supination can't occur because in this movement the radius moves around the stationary ulna. When there is a fusion, this pronation supination does not occur, called as radioulnar synostosis. So dear friends, in less than 1 hour, I have tried to cover the important images which have featured in exams till now or are very commonly asked. I hope that this session helps you in conquering orthopedic images and the instruments which can be asked. This is Dr. Apurv Mehra signing off. Thank you very much.